And good morning, everybody, and welcome to this meeting in public of the Board of NHS England. And can I extend a particularly warm welcome to those who have joined us in the room here in London this morning. At the same time, of course, the proceedings are being webcast to an enthralled global audience who are following our affairs with great interest. But I have to say, as a board, we really think that this is an immensely important way of conducting business. The NHS belongs to the people of England, and we are accountable for the stewardship of an extraordinary amount of public funding. And it's right that decisions that affect the health of the nation and the healthcare of the nation are taken in public. But we don't do all of our business in these meetings in public. Yesterday, for example, I spent a lot of time doing two things. One was formulating amongst ourselves our thinking about future strategy, and our Chief Executive will say a few words about that today. Secondly, we held through the afternoon and in the evening a set of meetings with an organisation called NHS Citizens, where we had the real privilege of sitting down with different groups of people who had specific interests, for example, children and young people, mental health, gender identity, and for board members being exposed to what people experienced as patients or as carers from the National Health Service, I think helped to flesh out in a highly sensitive and personal way what we're here for, and where people felt that the NHS was doing what they wanted and where they felt that NHS services could be improved or realigned or altered in such a way as to improve the patient experience. So that was very important for us. And then in the evening we conducted the second ever annual general meeting of the NHS, and that was in the QE2 conference centre nearby. My guess is about 250 people attended. It wasn't a dull meeting, and it would have been disappointing if it had been. But I can say, I think with confidence, that the board is better informed and more richly informed and more richly engaged as a consequence of those endeavours. Secondly, our meeting this morning has on it a number of items of really important business, but then, as is usual with meetings of public bodies in public, we will then go into a private session this afternoon where we have some key items which are, for example, relating to commercial transactions where there are negotiations regarding other matters which we feel have sufficient reason by virtue of the confidentiality and the sensitivity of the material that they need to be taken in private. But can I assure you that as chairman I require on each of those occasions a clear statement of why it is that the executive team are proposing to take that business in private rather than in public. As far as I'm concerned, the presumption is that we act in public. So let me then stress something about the nature of the meeting this morning for those of you who haven't joined us previously. It's not a public meeting, it's a meeting in public. The distinction being that we're not able to engage with those who have joined us this morning during the course of the meeting, but at the end of the meeting, informal conversations will of course be encouraged. It gives me great pleasure this morning to welcome some new members of the board. We are joined this morning by two new non-executive members of the board. That is by David Roberts, who is the upcoming chair of Nationwide Building Society, previously has been deputy chair of the Lloyds Banking Group, and by John Byrne. Sir John Byrne is the very distinguished clinical geneticist based in the Northeast, and somebody who has been a leading scientist as well as a clinician and an entrepreneur. They both bring with them new expertise and insights which will be of great benefit to the board. We also welcome a new national director in Dodge, who has previously had a career in the Department of Health, for many years, and absolutely delighted to welcome him to a new post around strategic commissioning. Commissioning is what lies at the heart of everything we do, and it's a great fortune for us, Ian, to have you to join us. So thank you so much for accepting our invitation, and it won't be a dull experience. Now, into the formal business of the meeting, I'm happy to report that I have no apologies. We are today a full board. On the agenda, there are, towards the end of the agenda, a number of items which are reports of committee, and we've decided on this occasion that we will take those as read, unless any member of the board indicates that they wish to unstar them and to have a discussion. As far as I understand, nobody has indicated such an intention, so we will take them as read. Two final pieces of preliminary business. One, the routine business of assuring you that there is no scheduled fire alarm. So should the fire alarm go off, our staff will escort people to a place of safety from the premises. And that secondly, I simply need to invite members of the board, please, whether to declare if there are any agenda items where there may be a conflict of interest. No? Right, thank you. Let me move on then to item 2 of the agenda, which is the minutes of the previous meeting, which were held in Birmingham on the 3rd of July 2014. I don't understand there to be any matters. Sorry, I don't understand. Let me first of all ask, are you happy with the minutes? That's the right order. Right, thank you very much. Secondly, are there any matters arising that are not otherwise on the agenda? No, there are not. Okay, thank you very much. There were a series of actions that were agreed to at that meeting. I have gone through with the Secretariat the list of actions. We have checked those which are complete and those which are on course, and there are none that I believe to be outstanding. So unless anybody has any questions about that, may I move on? Okay. Thank you very much. We move then to item 3, which is the Chief Executive's report, and I hand over to Simon.
Thank you, Malcolm. So I'll do 2 things. One, just pick out a couple of points from my more detailed report, and then secondly, get into some of the detail about the priorities for the National Health Service over the next 6 to 8 months. In terms of the items I specifically want to pick out, draw your attention to the fact that we continue to make good progress on mental health in terms of identifying, together with partners, feasible access standards, waiting time standards, which we would like to see introduced across the National Health Service beginning next year, recognising that it is over 25 years since waiting times standards were first introduced in physical health services, rolling out over many years to the position we've now reached. Obviously, we're not going to be able to do a comprehensive introduction of equivalent standards in mental health in one fell swoop next year, but we definitely want to make a start, and so significant work in hand there. Announcements will be made quite shortly. On cancer, just to update you, you will have seen that we have agreed with the Department of Health an increase in the funding for the Cancer Drugs Fund from the budget of £200 million last year to £280 million this year and next. We will now be consulting on the best way of ensuring that that extra funding achieves maximum benefit for cancer patients. We will also be working with NICE and with others on trying to get better alignment between the decision processes that are used in the Cancer Drugs Fund and the decision processes that NICE use. We have previously set out something called a commissioning through evaluation scheme, although I think we've now decided it actually should be called evaluation through commissioning, etc. And so there is work that we will be doing with NICE and with other patient and industry stakeholders on what that might look like over the coming months. And then just the third item to mention is that today the NHS is continuing with the transparency revolution through the publication of yet more transparency data on the performance of the NHS, and that is available at nhs.uk/mynhs. Pivoting then to the question of the principal priorities for us as an organisation and for the National Health Service over the next 6 months. What you see in my report is the proposition that we have got to work in parallel on objectives that will deliver over 3 separate timelines. There are a set of things we've got to continue to focus on intensely over the fundamental performance of NHS delivery now and through winter and into the spring to deliver on the commitments that we have made. Secondly, in parallel with that, we and partners have got to get the NHS to the best position it can, given the tight circumstances that will be facing us next year for 2015-16. And thirdly, while managing and commissioning for today, we cannot do that at the expense of the broader conversation and discussion we need about tomorrow. And that's why we are, as you know, intensely working with partners on an NHS 5-year forward view. Since we have specific agenda items on the 5-year forward view and on the 15-16 commissioning round, I don't propose to get into those in more detail now, although obviously happy to answer questions in a moment. And we do, of course, have a routine update on NHS performance, but I just want to share with you what I think is an important development that we have agreed this week in terms of how collectively the NHS is going to seek to support the front line of care, both CCGs and hospitals in care delivery. And that is that, as you know, we have a 3-way accountability nationally for NHS performance. NHS England, Monitor for Foundation Trusts, the Trust Development Authority for NHS Trusts. So for the first time today, David Bennett, David Florey and I are writing to all chief executives across the National Health Service, both commissioners and providers, describing a simplified, more coherent process by which we will be communicating with the front line of the NHS where issues arise, escalating and clarifying the ask and the funding that we're making available to frontline NHS bodies for the rest of the year. And one particular feature of this is that we are, as part of the extra money that we've made available, the £250 million that has been made available to catch up on where we want to be in terms of doing extra routine operations, NHS England, together with TDA, together with Monitor, the 3 of us are now inviting providers to identify the extra operations that they can provide for people on their waiting lists now through the end of November, and there will be, as it were, an amnesty for the performance incentives and penalties through November 30th, so that we really can catch up on where the NHS wants to get to in order to give people fast access to treatment before we then pivot to dealing with the likely increased pressures over the winter months for emergencies. So a detailed set of conversations now going on between Monitor and Foundation Trust, TDA and NHS Trusts, ourselves, the 3 of us hunting as a pack to ensure that we've got complete clarity about what hospitals say they can deliver and make sure they have the money to do so. So that, I think, represents an important development in simplifying, decomplexifying the superstructures that people are experiencing, while nevertheless recognising the importance of frontline autonomy and the decision making that CCGs and hospitals and other providers themselves need to make. Those, Malcolm, were the main points I wanted to draw out, but of course happy to take questions.
Well, thank you very much for that, Simon. Let's take some questions. I think Victor.
Just to welcome the fact that the first item on your report is about mental health, which is great. That's really good, and particularly welcome the parity of esteem point. It is a parity of esteem point in the waiting times, and I know that over the summer I wonder where you say a bit more about the work that's been done on the waiting times, because I know that it cuts across psychosis and crisis, which are key priorities for the parity of esteem board. But it's a good start. It's a good start.
Yes. Well, thank you. So we've obviously been working with NHS providers of mental health services, with user groups, patient advocates, other clinical experts to look at what is the current state of play and what is a feasible roadmap for improvement, recognising, of course, that there are constraints on the ability to get staffing in place. There are going to be very tight funding considerations for next year, but we want to make a start on that agenda to put a clear marker down that the direction of travel over the course of the next 3-5 years should be genuinely to achieve the same sort of parity of esteem when it comes to access to mental health services as has now been accepted for many years in physical health services.
And we're also doing something about physical checks, health checks for people with severe mental illnesses. Is that?
We are, and Bruce might want to comment on that. The point being that, as you know, the premature mortality, the life expectancy of people with severe mental health problems is up to 15 years shorter than people without for severe mental health problems. And so we've got, I think, the world's biggest financial incentive scheme now to get health checks, physical health checks for people with mental health problems. But I don't know, Bruce or Jane want to.
Or Jane?
I simply want to highlight the importance of the relationship between physical health and mental health. And I think for a number of decades it's probably gone unrecognised, but the science has now got us into a place where we have a very, very clear association between certain types of mental health and physical health. We know, for example, that people with significant physical conditions, whether they be diabetes, motor neurone disease or others, also are subject to, if you like, consequent mental health problems. And we also know that there's a definite link between certain types of mental health problems, in some cases genetic, such as schizophrenia and colorectal disease, or in some cases less well defined, such as the relationship between mental health and smoking and the consequent cardiovascular and other diseases, cancer that fall from that. And I think it's an increasing recognition of those relationships which is leading us as part of a greater package to look at how we can ensure that people within hospitals that provide, if you like, physical care, so the regular acute hospitals, have greater access to mental health expertise and vice versa.
That's great. Can I just thank Bruce for that, but also just mention that we'd also, it'd be useful if we also bear in mind that there are people with learning disabilities who also have the same, and I don't know whether that's part of the same agenda or not, and also make a request that we have a continuing report to the board on these issues because they are so important.
We'll make sure that that's linked up between Jane and I.
Thank you.
Myra?
Congratulate Simon and say how welcome it is that close collaboration between Monitor TDA and ourselves. But I'm sure that you would want to slightly rephrase what you said in terms of hunting as a pack. I'm sure that out there the system is welcoming that alignment, as it were, and not having too many different stretches for them.
Yes, exactly. And the three of us are going to convene meetings of all Trust Chief Executives across the country, together with CCG, Chief Officers and Chief Executives, local authority Chief Executives invited as well, end of November, early October, 4 different regions of the country, in order to not just discuss the here and now, but also the conversation about what we need to get right for next year. And by then we hope to have published our shared forward view, and that will be a chance for a meaningful conversation in every part of the country about how to pivot to that agenda as well.
Can I just underline actually the sheer importance of this? I mean, it's most welcome because TDA Monitor and NHS England have different roles, different responsibilities, but they come across in different layers on the provider side, and it's, I think, a great cause of frustration and fragmentation if we're not well aligned. And I think the opportunity to work much more closely and to prepare not only for the coming winter and beyond, but also for the 5-year view is actually a critical step forward for the leadership of the NHS. And Simon and the other 2 chief executives, I think, are to be commended for bringing about this new operative model. Any other questions for Simon?
Just
Ed.
one, Simon, sorry. It does relate back to the conversation we had in July. Over the summer and up to now, have we made progress with the arrangements for the Better Care Fund and accountabilities and the way in which that's being worked through jointly between the parties?
Yes, thank you. I'm going to ask Barbara to respond. I think the answer is we absolutely have. I think the programme management arrangements we've got in place, Andrew Ridley as the project director working with the LGA, CLG, ourselves and other partners. We got the first 5 of the local plans fast-tracked and essentially approved. So I think that is moving in the right direction. But Barbara, why don't you?
Yes, I mean, I think we've made a huge amount of progress on the Better Care Fund over the last couple of months. As you know, I'm now the SRO for this across not only NHS England, but I do that across government in terms of supporting the Better Care Fund to make sure that it delivers what we all want, which is much better integration of health and social care for patients in order to ensure that they're kept as well as they can be, and where they do have problems, that health and social care services are integrated and seamless, with the end point being really that that helps us in the longer term in terms of the NHS and local authority financing, because it reduces the demand on acute trusts and reduces the demand for residential care, which we know is not what patients want. If they don't want to be in hospital, they don't want to be in care homes unless they need to be. There now is quite a complex programme in place which is overseen by ministers as a ministerial board and an officials programme board, which we meet every fortnight in the officials programme board. As Simon says, we've got 5 plans that were fast-tracked in order that we get a lot of learning from how these plans, how we need to shape them, because we've got a very significant assurance process now going on all the other 145 plans, 46 plans that need to be assured to a very tight timetable, because people need to be able to plan their resources for next year. So all that work goes on, and it will be very important for us now to map that onto what we are doing in terms of planning. We've got good resource, we've got good support out in the field. Our people in the regions and more locally placed people in NHS England are the ones who are kind of doing much of the work in ensuring that the plans that the health and wellbeing boards have produced and need to have significant autonomy for, because the whole point of this is that it's a devolved system which allows local people to decide what's best for them across their community. But we also need to make sure that we are confident that those local economies have got all the support they need to get them to be the best they can be.
Good. Maybe, Chair, we could flag that at some point before April next year, we just have that assurance to the board that we have all of the mechanisms we need in place, that the system needs in place to assure ourselves of both value for money and effective care integration at that level.
Yes, I think we should mark that up as an action point. Thank you. Anything else on Chief Executive's report? In which case the board notes the report. Thank you, Simon.